When I was training to be a pediatrician, I decided that I did not want to have to deal with the run-of-the-mill pediatric problems. I was more interested in the problems that did not have a solution. So I had a particular interest in pediatric oncology. There was one little boy who had a brainstem tumor, and he died all alone in his room. His family had abandoned him. And that was the beginning of my ventures into pediatric brain tumors. In my job, there are ways that you can help your patients and your families, even if you can't cure the patients, and that's sort of what gets me through on a day-to-day basis. DIPG stands for diffuse intrinsic pontine glioma. It affects about 250 to 300 children per year in the United States, we think. The biggest problem with DIPG is that we have not made any headway in the outcome for these patients in more than 3 decades. It's in a place where you can't do surgery to take out the tumor. We recommend radiation for the tumor, which temporarily stops the tumor from growing, but almost all children progress and then pass away within a year of diagnosis. So for a long time, we assumed that diffuse intrinsic pontine glioma looked and acted biologically like adults with glioblastoma or malignant gliomas. And we found out that once we started to biopsy these tumors a few years ago, we found out that indeed they were very different biologically from the adult tumors. So now we know that they're a distinct entity. Up until the time where we started to get tissue samples on these children, our hands were tied. We were, again, mimicking what was going on in the adult world, and the chemotherapeutic agents that we would give to adults were not working for this tumor type. So now that we are studying this disease, we're learning more about the biology of the disease, we're better able to select drugs that may potentially work for this tumor. Now, the biggest problem, one of my interests, is CNS pharmacology, and one of the big problems with this tumor is we think that chemotherapy doesn't actually get into the pons, which is the site of the tumor. We've done some animal studies which have confirmed that if you look at the drug penetration in different areas of the brain, less gets to the pons, and that might be a reason why it's not working for these kids. We give most of our chemotherapeutic agents either by mouth or intravenously, and they have to cross through what we call the blood-brain barrier in order to get to the pons. We have looked at alternate methods of delivery, including convection-enhanced delivery, where a catheter is placed through the skull directly down into the pons where the tumor is, and give drugs directly there. We're currently looking at intranasal drug delivery in our non-human primate models to see if we can increase the penetration of drugs into the central nervous system. So the intranasal drug delivery is actually already used for a number of different drug types. So drugs for Alzheimer's disease, migraines, anti-seizure medicines can be delivered through the nose. I'm not aware of anybody that's been trying to administer chemotherapeutic agents through the nose, but you're able to bypass the blood-brain barrier through the olfactory epithelium. And you can also get drug tracking or drug delivery through nerves that innervate the olfactory epithelium and go right back to the pons. So we think that it's possible to get direct drug delivery up your nose to the pons where the pontine tumors are. So we've been evaluating different types of chemotherapies in our animal models to see which ones would have a pharmacokinetic advantage if we administered it intranasally versus by mouth or by vein. We've looked at 3 different drugs at this point. One drug called periphosine has almost 0 penetration into the central nervous system. And it appears that if you give it intranasally, you can get a little bit more than you can as if you give it intravenously. So that is exciting for us, and we're trying to increase the dosing, the dose that you can give intranasally to see if we can increase the levels in the CSF. We also looked at a drug called temozolomide, and it looks like you can get more into the CSF and less into the periphery, so you would actually get more efficient delivery to the central nervous system and less systemic toxicity if that pans out. And then we looked at a drug called valproic acid, which is used very frequently in neuro-oncology, and it also appears to be more efficient when given intranasally. So these are still in animal studies right now. Our goal now is to increase the dose to see if we can reach effective concentrations in the CSF and then hopefully translate that into effective concentrations in the central nervous system tissue. So the implanted wafers are not used very frequently in pediatrics, and they can't be used in the DIPG population. You basically have to resect some of the tumor tissue and create a cavity to put the wafers in. In the PONS, you can't do surgery and resect part of that because the tumor cells are infiltrating with normal cells, and you need those normal cells for vital functions. And so the wafers are not really an option for DIPG. They are used in some, I would say some adolescents have been using, we've used wafers in, but it's not used that frequently. We have tried things like blocking drug efflux pumps, like P-glycoprotein pumps with other agents, but that appears to be too toxic at this point. I look at other tumor types as well. So again, it goes back to my history of trying to choose the most problematic rather than the easiest to treat. So in addition to DIPG, my research focus is now on gliomatosis cerebri, which is a diffuse infiltrating tumor that affects both adults and kids. And I think if we study the biology of those tumors, we may see some overlap with DIPG and maybe get some hints into the tumor pathophysiology. That's a very good question. It's one of those, until we have the answer, we won't really know, but I think everybody's problem is drug delivery to the central nervous system. We have to better understand the pharmacokinetics in the central nervous system and how we can get drugs to the tumor site while protecting normal tissues. It's particularly important in pediatrics to protect the normal brain. So if you don't want to increase drug delivery to the central nervous system, if you're going to increase toxicity as well, it's one of those, you want a tumor-focused increase in delivery. And I think once we figure that out for pediatrics, that will be very applicable to the adults. I think the way we currently develop drugs is inhibiting us. I think we need to take a step back and decide what the questions are. So right now, the way we develop drugs in pediatrics is we generally have some safety data in the adults, and then you test to see if it's safe in kids. You increase the dose to the maximum tolerated dose, and then you move to phase 2 testing where you look to see if it's efficacious. So nowhere in there are we testing to see if we're reaching the effective dose at the tumor site, and that's what needs to change. We need to emphasize preclinical testing where we define an effective dose and an effective schedule, and then see if we can achieve that in our early clinical trials in kids. Right now, the way we determine an effective dose is preclinically, where you put drugs on tumor cells, the tumor cell lines, and the cell lines are exposed to the drug for 24, 48, or 72 hours continuously, and usually at higher dose levels. And that's hard to mimic, particularly in the tumor site in the central nervous system for pediatric patients. So right now, what we're trying to do is, number one, answer the question, if you keep increasing the dose, do you get a better response, which would help us again in our clinical trial design? What effective dose would get the effect that you want in the tumor cell? So if you're looking for cell kill, what kind of concentrations do you need to get that in the tumor cell? And then see if you can mimic that in an animal model, usually in a lower species like a mouse or a rat model, and then see in a non-human primate model if those exposures are safe and tolerated in the monkeys. I think the take-home message to the neuro-oncology community is that we need to rethink how we're doing our clinical trial designs and drug development in general. The take-home message to the parents is to try to understand that while there may be some drugs that are in development right now, it doesn't mean that that is something that should go directly to the clinic. We need to be patient and figure out what's the safest and most effective way to treat your children with the best drugs that have the best scientific rationale.